All right, I'm going to be following up from Charlie's presentation and showing some of the work we've been doing around mapping and data visualization. I spend most of my research career using geospatial tools and spatial epidemiology to study chronic disease, and in the last month and a half, I've been powering up to use these tools to try and do something useful around the COVID pandemic. So this idea that place and geography mattered is very, very old. We can go back to 400 BC for airs, water, and places as maybe the beginning of this understanding that to understand disease transmission, we can think about the characteristics of place, nearness, adjacency. Many of you should be familiar with this map. This is the classic 1854 map from John Snow on the location of cholera cases in London. Ironically, in this first version of the map he created, he put the pump in the wrong place, and in a subsequent map actually corrected where the pump location was. But this is one of the earliest uses of mapping in public health to understand disease location and identify risk factors. Another classic is the NCI Cancer Atlases, published first in 1975. The 75 publication looked at county level mortality from cancer from 1950 to 1969. And it was really the process of creating these maps that generated a lot of the seminal thinking on how to use color to depict risk, how to display maps in a way that conveyed information about disease processes, disease prevalence. And so not only were the maps created, but in many ways the science of how we use spatial information to talk about disease was really pushed forward through this process. And so this has been, this is a classic of spatial epidemiology and thinking about how to use mapping. As soon as we started mapping cases, we started to think about privacy issues. If I throw a case location on a map, it becomes actually relatively trivial to de-identify that location and then backtrack individuals based on these mapping tools. And so there's been a lot of literature on how easy it is to identify patients or cases from some of the maps that we publish or put onto interactive mapping sites. And if we look back at Johns Hopkins COVID map that I'm assuming everybody is intimately familiar with, this is a screenshot from March 9th. At that time, they were putting red dots on the map that seemed not to necessarily correspond to counties or zip codes or cities per se, and they seemed to actually correspond to locations of individuals. And I've highlighted 4 of the dots here on this screenshot. And sort of within a couple of weeks of these maps going live, people who are interested in patient security, patient privacy, started delving into these maps to see if actual patient locations could be recovered. And it appears, as best we can tell, that Johns Hopkins was using some kind of jittering to sort of hide exactly what the dots corresponded to. But there was some consternation about the location of some of these cases. On March 9th, there was a dot on the map located in Baltimore County. Baltimore Department of Health had said there were no COVID cases at that time in Baltimore. There was articles in the Baltimore News about how the Johns Hopkins site was saying that there were COVID cases in Baltimore County, yet the Department of Health was not confirming any cases. Almost immediately after this publication, the Johns Hopkins COVID site changed its format and started putting all of the dots at the center of counties, except for some cities like New York City, where they just put 1 dot in the middle of New York City. And so the privacy issues that we've talked about for years have sort of played out now today with the COVID pandemic. Our work, we started thinking about mapping vulnerability and thinking about populations that were at risk for severe COVID On March 16th, we published our first just static graphic maps on our website. This is a map of county level estimates of COPD, emphysema, chronic bronchitis, just to start thinking about where the most vulnerable populations, based on the information at the time, were located. March 17th, we launched our first interactive map with policymap.com. This is a map of the ratio of individuals 65 years and older per hospital bed in the United States. Gray areas are counties in the United States with no available hospital beds. And the darkest red indicates areas with very high numbers of older adults per hospital bed. So 137 or more older adults per hospital bed. This is when we first started thinking about this allocation of both patients and supply of hospital beds. We quickly started working with Charlie after this. March 17th, we published our first map indicating counties that had the highest number of older adults and the lowest number of available hospital beds. March 24th, we published our first interactive map and started hosting it ourselves. This is the available ICU beds under normal conditions. And I'm going to try and put maybe this into the chat. I don't know if I can do that. I'll put it in the chat afterwards. We now have two interactive sites. One is a mapping site and one is a data visualization site. And I will throw these links into the chat when I'm done with my talk. These sites are actually being used by a lot of organizations. The U.S. Army Corps of Engineers, Army Engineer Research and Development Center, U.S. Army Indiana Intelligence Center, the U.S. Air Force and the Pentagon, Federal Reserve Board, the Washington State Government, Maryland State Government. I got numerous emails from sort of local county planning offices sending me notes asking for more data or saying that they were actually using our maps and it was helpful. So I'm going to switch now. I'm going to stop sharing this screen. I'm going to share a different screen. And let's go to share screen. This should be it. So you should now see a map of the United States color-coded by counties. This is a fully interactive map. You can move the map. You can zoom in, you can click on any county and recover the data that's underneath that county. What I'm showing you now is the availability of critical care beds under the medium surge response that Charlie talked about. So this is our estimate of the available beds when the hospitals do a pretty intensive surge response. Areas in dark red are the areas with the lowest ability to accommodate patients. And what I'm going to lay over the top now is these are counties that are at high risk for seeing their healthcare systems severely stressed by the demand for patients compared to their ability to provide hospital beds. This assumes the 30% social distancing model and a medium surge response. And this is timed to severe stress or being overwhelmed in the next 42 days. We're updating these maps every week, providing updated data. You can click on any county and it pulls up the data for how many days until the county will be under severe stress. The mapping tool has got quite a lot of layers that you can play with that mainly are now depicting sort of these surge models that Charlie has been building. And then I'm going to switch to a separate tool. Let's get this going. I'm switching now to our data visualization tool. So this tool takes the data that Jeff Shaman is producing on the number of projected cases per day for the next 42 days. This is all of the United States. You can zoom down to any state. Let's go to New York State. You can zoom down to any county in New York State. And then over here, let's take a look at available hospital beds, medium surge, New York State. So what I'm depicting now is a combination of Jeff Shaman's projections on the daily number of cases under a 40% reduction in social contact on the left, and then the corresponding estimate of the available critical care beds day by day under those same circumstances for all of New York State. At the bottom here, you can change the assumptions about the extent of social distancing and see the fluctuations in available hospital beds. I've now clicked on our worst case scenario. This is 20% reduction in social contact. Currently, Jeff Shaman's models are actually showing a resurge of daily cases if we were to only have a 20% reduction in social contact in the US. These data sets get updated every Monday morning. Jeff's team is currently working on a set of models that incorporates the various states that are trying to open up their economies and relax social distancing. This provides you also county by county data, so you can zoom into a specific county. This is Manhattan, New York County. This is under 40. So this is the estimated number of cases each day for the next 42 days with a 40% reduction in social contact. And we're showing the 75th percentile, the 50th percentile, and the 25th percentile estimates. So both of these are available, freely available online. Let's see, I'm going to reshare. So a lot of people are using these sites. I just found the chat function. Maybe not. A lot of people are using these sites. The U.S. Air Force is using these sites to try and estimate force protection for the U.S. Air Force bases around the country. So they're looking county by county at their Air Force bases, looking at projections. The Federal Reserve Board is using these data to try and understand the economic impact of the COVID pandemic. Army Corps of Engineers, who we've been working with quite closely, are using these tools to try and plan for where to put field hospitals. So there's a variety of uses of these data. Maryland is currently going to have a debate today about trying to understand what they can do to reopen, and Jeff Shaman is going to be presenting there, and they have been using our maps and estimates. This has been an effort across multiple groups. I've mainly been responsible for bringing together data and understanding how to visualize it and present visualizations and get our servers up and running. So there's much thanks to the many people who've contributed data and expertise to pulling together the data that sits behind these visualizations. So I will stop now and take any questions.
Perfect. Thank you, Andrew. I see Wayne Hendrickson has a question. I'm going to allow him to talk. Are you there, Wayne?
I am here, but I didn't actually have a question. I did something wrong, I think.
Okay. Go ahead and mute yourself, Wayne. I do see that there's a question from Ann Tergas, and it's something that I asked earlier, and that is, what is the percent estimate of the current level of social distancing in New York City and New York State? Are we at 20%, 30%, 80%? Based on the model numbers?
So I don't know the exact answer to that question. It varies across the city. I mean, the way Jeff has explained the social distancing parameter to me is that if you say 40% reduction in social contact, it means that there's a 40% reduction in the number of instances where there is the possibility of transmission. My sense is that probably New York City in many parts is got higher social distancing than we're currently putting into these models, but I don't have absolute data on that because the parameter that goes into these models is really about the reduction in the opportunity of transmissions. Whereas the kinds of data that we have available are like cell phone data that tell you the number of times somebody left their house. It doesn't tell you the number of times that they then intersected with somebody who could have infected them, or if they were infected, the number of times they intersected with somebody who was susceptible. And so there is this sort of disconnect between the kinds of data we use to understand how locked down people are and the kinds of assumptions that get put into the models. And we're trying to bridge that sort of gap between those two perspectives.